channel. So in this chapter we are going to study about the ventricular arrhythmias. So this is our last video regarding arrhythmias, in which we are going to cover ventricular tachycardia, ventricular fibrillation and premature ventricular complexes. Now before studying each and every ventricular arrhythmia, I would like to revise few points regarding these ventricular arrhythmias, that what we expect in our ECG. So the first point that we expect in ventricular arrhythmia is the broad QRS complex. Now if you remember the basics of arrhythmias video, you would find that ventricular arrhythmia starts with the foci, right? Foci that is present in the ventricle. So any foci that is present in the ventricle will generate the impulse, and this impulse will carry to other parts of ventricle, right? Now this conduction is through intermyocytic, right? This intermyocytic conduction is very slow conduction as compared to neuronal. Since it is an intermyocytic condition and it is slow, we will get this on ECG as a broad QRS complex, like this. And in neuronal conduction, it's a regular one and it's a very fast. That's why we get the narrow QRS complex. So the first thing is the broad QRS complex. The second one is increased ventricular rate. So the basic ECG findings that we are going to find about every ventricular arrhythmia is broad QRS complex and increased ventricular rate. Before studying particular ventricular arrhythmias separately, I would like to make you aware regarding few terminologies like stable patient, unstable patient and pulseless. Why? Because most of the ventricular tachyarrhythmias or ventricular arrhythmias will require the management as per the patient's hemodynamics. Like for the stable patient, hemodynamics are within normal limit. Right? Unstable patient can present it to you with altered sensorium. Patient can present it to you with the shock, with organ failure or any hemodynamic instability. What about the pulseless? There will be no central pulse, right? For the most of stable patient, we will go for pharmacological cardioversion. And for most of the unstable patient, we will go for synchronized cardioversion. And for the pulseless, we will start with the ACLS protocol of cardiac arrest. So what is the difference between the unstable one and pulseless one? What is the basic pathophysiology behind these two terminologies? The pulseless patient will have no coordinated ventricular contraction. So there will be no organized rhythm to find out R wave. On the other hand, the unstable patient will have some hemodynamic instability, but this patient have a little bit of organized rhythm. Now what to do with this organized and disorganized rhythm? So whenever we put this patient on defibrillator, right? We put this patient on a defibrillator so that we can deliver the shock. Now if we ask defibrillator to give shock in pulseless patient, then there is a possibility that defibrillator might take a long time to identify R wave. So if it takes a long time, then there is a delay in delivering shock. So patient might get worsen. So we go for desynchronized shock. I hope you know what do you mean by the synchronized shock. Now suppose patient is unstable, and in this case defibrillator will able to find out R wave. So we will deliver synchronized shock in this unstable patient. So synchronized shock always be given at R wave. And since defibrillator cannot find the R wave in pulseless ventricular tachycardia or ventricular rhythm, we deliver desynchronized shock in pulseless. The first arrhythmia that we are going to study is ventricular tachycardia. So ventricular tachycardia, that is VT, consisting of two types. The first one is monomorphic VT, and the second one is polymorphic VT. First, we will study about the monomorphic one. Now, what are the causes of monomorphic VT? There are few causes that we should remember. The first one is old MI, right? Then ischemic heart disease, then dilated cardiomyopathy, then hypertrophied obstructive cardiomyopathy. Now, what happened in those conditions is that due to these following conditions, the ventricle gets scar, and this scar will behave as a re-entrant circuit, and this will create the impulse, and we will get the VT. So whenever there is a single scar will always produce monomorphic VT. Understand? So the single scar will behave as a re-entrant circuit, and it will create the monomorphic ventricular tachycardia. What are the other causes? Other causes like electrolyte disimbalance. We have hypokalemia. We have hyperkalemia. We have hypomagnesia. There are few drugs which are also responsible for VT. What are those? It's a digoxin, toxicity, class 1 antiarrhythmics, then TCA cycle toxicity, and the cocaine. So these are the basic causes of monomorphic VT that one should remember. So this is the ECG of monomorphic ventricular tachycardia. You can appreciate the rhythm is regular, RR interval is equal, right? Then there is a wide QRS complex. The QRS is wide, and it's a monomorphic, that is the same shape QRS complexes, right? So whenever you see the ECG pattern like this, always remember it's a VT and the monomorphic. Now how to manage this patient? To manage this patient, we will categorize this patient into the stable one, unstable one, and pulseless. As we know, we will be going for DC shock in pulseless. In unstable patient, we will be going for synchronized shock, and in stable patient, we will go for pharmacological cardioversion. Now, how do we do the pharmacological cardioversion? So we will start with the amiodarone. What is the dose of amiodarone? It's a 150 mg bolus over 10 minutes, right? Followed by 1 mg per kg for next 6 hours, and then 0.5 mg per kg for next 18 hours. After pharmacological cardioversion, we will treat underlying cause. So I hope you have a fair idea about the management with respect to stable, unstable, and pulseless patient. So what is the importance of this stable, unstable, and pulseless patient? Now in exam, they are not going to put that patient is stable, unstable, or pulseless. They will be giving you the findings, and according to that findings, you have to mark a question about the management. Okay, so this is about the ventricular tachycardia. that is monomorphic ventricular tachycardia. What about the polymorphic VT? So polymorphic VT is usually associated with prolonged QT interval, right? The most classical polymorphic VT is Torsades pointes. What is the characteristic feature of polymorphic VT? The characteristic feature is there is a multiple different complexes with changing polarities. Now, what do you mean by different complexes with the changing polarities? So this is the ECG of Torsades pointes. So you can appreciate there is a changing in the polarity. This is the pole. So this is your lower pole. We can say this is lower pole and this is your lower pole, and in between it's a high pole. So it is like changing polarities, multiple polarities, right? So ventricular rate is typically 150 to 50 beats per minute, and the QRS complex is more than 120 minutes. Now, what are the causes of this polymorphic VT? You can take a screenshot of this image as well so that you can revise it quickly. Now, what is the causes? So there are acquired causes and there are congenital causes. So the common cause is myocardial infarction, then it's a hypokalemia, then hypocalcemia, then hypomagnesia. Then there are few drugs that are responsible for TDP, and those are antiarrhythmic drugs like class 1A, 1C, and third one. Then there are macrolides. In macrolides, erythromycin is most important drug that one should remember. Then there are congenital causes like long QT syndrome, right? Now, how to manage this TDP? Now, remember in pulseless VT, we said that there is no organized R wave, that is no organized contraction. TDP also present you as a no organized contraction or disorganized contraction. So polymorphic VT, we will treat it as cardiac arrest rhythm. Here we will start with the defibrillation directly. What do you mean by defibrillation? That is desynchronized DC shock, right? Because there is no identifiable R waves that can be taken by defibrillator, right? So we will go with the defibrillation, that is a DC shock, and after that we will start this patient on MgSO4. And what is the dose? It's a 2-gram bolus. And after that we will look for underlying cause and we'll treat accordingly. Right? Then what is the ventricular fibrillation? As you can see, the meaning lies within the name, that is the fibrillation. So these are the waves that are fibrillating waves. There is no organized R wave, P wave or QRS complex. So this is the ventricular fibrillation. And what is the management of this patient? The management of this patient is to treat it as a cardiac arrest algorithm. Now, what is the significance of this ventricular fibrillation? So ventricular fibrillation is life-threatening condition in which one can lose his life. Right? So it is the most dangerous rhythm that everyone should be scared of, and that's why we always try to prevent ventricular fibrillation. Now, what are the common causes? The common causes consisting of this electrolyte abnormalities, ischemic heart disease, cardiomyopathies, sepsis, hypoxia, trauma, post-cardiac surgery, congenital long QT, Brugada syndrome, and arrhythmogenic RV cardiomyopathy. What about the clinical features? So patient can be presented to you with this sudden collapse. Patient could be unresponsive. Patient could be no palpable pulse, or there is a gasping condition of the patient. Even patient can be presented with the dilated non-reactive pupils as well. And as we said, it's a cardiac arrest rhythm, right? So this is very life-threatening condition. And why do we need to study about the ventricular tachycardias or ventricular arrhythmia is that every ventricular tachycardia, whether it's a monomorphic VT or polymorphic VT, they have a great potential to develop or to land up in ventricular fibrillation. So that's why it is very important to study and treat those monomorphic and polymorphic VT at that particular, so that it wouldn't develop into ventricular fibrillation. The detailed video regarding this ventricular fibrillation or the cardiac arrest algorithm, we will be covering this in ACLS protocols. ACLS protocol is a very big topic and it has to be taken with the separate chapters. So we will study this cardiac arrest algorithm in that chapter. Now the third one is the premature ventricular complexes. As you can see, the premature ventricular complexes are the extrasystole due to premature discharge from ventricles. Like there is ongoing normal sinus rhythm and suddenly ventricle gives discharge or impulse through intermyocytic conduction, and there is a large QRS, broad QRS complex that lies after PQRST complex. Now what are the characteristics finding in this premature ventricular contractions are, there is no preceding P wave. Since it discharge is coming from ventricles, so there is no preceding P wave. Then there is a void QRS complex and there is a discordant T wave. What do you mean by discordant T wave? So ST and T, this both will be in opposite direction. I hope you can appreciate Q, R, S and T. So S wave is in different direction and T wave is in different direction. Similarly, what do you mean by ventricular trigeminy? So ventricular trigeminy means there is a two normal sinus rhythm followed by one PVC. And what do you mean by ventricular bigeminy? There is an alternative sinus rhythm and PVC, right? You can take a screenshot of this image so that you could revise it very quickly. Usually PVC doesn't require any treatment and we just have to look for red flags. Now what are the red flags in PVC? The first one is frequent PVC. What is frequent PVC? It is more than 10 per minute, right? Or more than 10 to 15% of burden. Right? So these are the red flags that one should understand in terms of ventricular complexes, premature ventricular complexes. So this is it for these arrhythmias. I hope you have cleared your ideas regarding all arrhythmias. In the next chapter, we will be starting with the ACS, that is acute coronary syndrome. So see you on the next video. Thanks for watching. Keep studying and I hope this will help you to ace in your exam. Thanks for watching. See you on the next video.